Hello and welcome back to Kelly's Anesthesia Tips. Well, I couldn't do it. I was so close to finishing today that I thought I'm going to get it finished. So we'll wrap up part 4 of this section. And if you started with me on part 1, we're down to the conversion factor total and what that means. And the conversion factor has a couple of dual meanings that are sometimes confusing. The one thing that I would like to do though is just thank you, because this gave me an opportunity to remember that meeting Joanne and I did in Orlando that we had such a blast at. She was so much fun, and she would have loved she would have loved this way of teaching. All right. So conversion factors. The conversion factor is the dollar amount that is multiplied by the total units to obtain the anesthesia charge, but it has two sides. There's a conversion factor for the charge side, and there's a conversion factor for the payment side. And I'm going to talk about them both, and then I'm going to tie it into examples to make it a lot easier to understand. Because I'll tell you, hindsight sure is 20/20, but I still remember how confusing all of this was. One thing that is important to know about the conversion factors is that they will vary by your geographic location. I'm going to use Florida as an example because that's where I'm from. Another thing that practices take into consideration are whether or not it's an all-MD practice or whether it's a practice that has CRNA or anesthesia assistant employees, because there are associated costs with those additional employees. And then geographically, of course, it costs more to live in New York or Miami than it does to live in and around Lake County, Florida. Another thing that I like to point out is that Medicare conversion factors are unrealistically low. In order to kind of point that out, when I was putting this together, I left in my information from 2013. I didn't go all the way back to 2008. I keep track of all that good stuff. But 2013 was, 8 years ago, and just to me, it's kind of like mind-boggling that instead of getting paid more, you somehow end up getting paid less. If you have the time and the inclination, there is such a thing in the anesthesia world as the 33. It might be the 33 and a third % problem, and I think it's even dropped down now to about 25% or somewhere close to that. But anesthesia is underpaid by Medicare when you compare it to all the other specialties. There's loads of information out there. I'm not going to go into that, but just, to bring it to your attention, if you're interested, there's plenty of places to look that up with. So back in 2013, published rates, which are okay to share. If there is a published rate, and this is not what you charge conversion factor, this is what you get paid conversion factor. Now you don't discuss your contracted rates with other friends or no friends. That's private information and protected information and proprietary information that you don't talk about. You can talk about, though, the published rates. I mean, anyone has access to them just by pulling that information up. But you don't share what you charge with other practices. I should have included, but I didn't, but it's easy to find. There is an ASA managed care survey that is incredibly important if you're trying to, coders and billers don't really care so much about this, but administrators certainly do, and your physicians do. If you pull up that managed care survey and make sure you're participating in it, then you'll have a much better idea of what rates are for your geographic location as far as contracted rates that you're not allowed to share. All right, let's move on because I still want to keep it short. I just showed you 2013, and back then our rates for Medicaid was $14.50 and $15.08. Well, that's still the same. I guess I should have double-checked that, but I don't think they have changed since last year at all. And our national Medicare conversion factor, which was the one I have, was last updated November 23rd, and I think that was their second printing of it. So make sure that you do have the most current if you you might have it already built into your system, or you might have a program that calculates that for you. But here's the zip file if you don't and if you're using paper. So right now we're looking at a 2021 national conversion factor of 20.0547. Here in Florida, Fort Lauderdale and Miami are both higher than the entire rest of the state because the cost of living is much higher down south there. For purposes of our examples today, I'm going to use the 1995 Medicare rate to show you how Medicare processes claims. All right, so you know what a conversion factor is. We have a charge conversion factor, and then we have a payment conversion factor. So where we started earlier with our, first one in this series of 4 was the time units and the base units. So it's okay that they're out of order. You're still going to get to the same place. I promise you, whether you started with time and then base or started with base and then time, you're still going to get to the same place. We have our modifying units, and then this conversion factor that we're talking about, which is your anesthesia fee for the charged amount, and then your payment amount. So let's see how it works. Okay, and I use round numbers. So for your charge conversion factor, I'm using $100 just because it's a nice, round, easy way for me to show you math, and I don't have to check my math. When I get to the, Medicare one, I have to do it twice just to make sure I don't make any mistakes, but this one's easy. So we're going to do a surgical knee arthroscopy with our anesthesia code that gives us 4 base units. We're going to round it to a nice, interesting 1 hour, and we're going to use the 15-minute time increments. So there are 4 15-minute intervals in an hour. We're going to add those two together, and the patient has a systemic disease, so we're going to include a P3 modifier, and we're going to have a total of 9 units. 4 for our base, 4 for our time, 1 for the P3. And if the patient was 72 years old, you would be adding another one on here. But now hopefully you understand how this all works. So we have a nice round figure of $900 for our bill. Now let's see how an insurance company would process that. And again, these are examples. These are not real life at all. This is just so you understand how it works. So I'm going to pretend Aetna is contracted with you, and you're going to file your claim for your anesthesia bill of $900, and you have a contract with Aetna where they will pay you $80 per unit. So they will approve, and we'll pretend they're going to pay and not give the patient a copay or deductible, but if you need help with that kind of stuff, that's what the suggestions are for. We're just going to call this nice and flat, and Aetna approved and paid $80 per unit, or $720. Your billing department will be adjusting off the $180. That's the difference between these two, and the patient doesn't owe anything. Of course, that would change if there were copays, deductibles, etc. But we're just doing this for ease, simplicity of learning. Now let's look at that same bill for a Medicare patient. We still want our anesthesia charge to be the same because our conversion factor should theoretically be the same for all of your patients, no matter what kind of insurance they have. And how I could, if you've been to meetings that I've talked at, I talk about why I as a patient would not like my bill to be higher than my father who is on Medicare. If we both had the same service for the same amount of time, I think it's only fair that the anesthesia bill is the same for both of us. That's my personal opinion. Okay. In my locality, which is rest of Florida, Medicare will pay 8 units. They're not going to pay that additional 1 unit for the P3 modifier because traditional Medicare bundles it into the service. And we know that because I'm in the rest of Florida, it's only $19.95 per unit under their fee schedule. So by calculating those 8 units by $19.95, Medicare will approve $159.60. I'm going to pop back just to show you the disparity. So $720 is closer to what our actual fair fee is, but Medicare is going to pay us so much less. So if you're researching into that 33 1/3 problem, this is what you're going to, come away with, that we are underpaid for our anesthesia services, which just means that we have to work so much harder for our doctors to make sure that we're getting every penny that, you know, they've worked for, earned, and deserved. So in this instance, Medicare, this is in any state, doesn't matter which one you're in, they're only going to pay 80% of their approved amount. Of course, you know, when things get back to normal, there will be that sequestration on there. You may have an upward or a downward based on your MIPS adjustments for your incentive programs. But for these purposes, I'm just giving you straight up, you know, easy. Here we have to adjust almost the entire bill, $740.40, and then the patient or their copay is responsible for the difference between what Medicare paid, which was the $127.68, and what they allowed, which was the $159.60. So here, you know, I like to point out your anesthesia tips are, your anesthesiologist or anesthesia provider is with the patient before, during, and after a surgical procedure. Your anesthesia time starts before the surgery. It has to. They're with the patient the entire time of the surgery. They have to be. And then they're with the patient after the surgery is finished so they can reverse the drugs, take the patient to the PACU or the post-anesthesia care unit, turn them over to a non-anesthesia person when they're capable of being turned over. So our fee covers an array of time, before, during, and after. The fees that we bill for are just for their professional services. So when you're explaining to a patient, and you know, if you're billing for both the physician and the CRNA, and again, if these are things you want to see in additional videos in the future, let me know. But you're going to be explaining two different bills in that circumstance. For this one, we just use straight one bill. Typically, your facility, either the hospital or the ambulatory surgical center, are going to bill separately for whatever drugs were used, the equipment, the supplies, and the room. For our intents and purposes, it's just the physician's fee. So with that, I am going to end with what I wanted to become my mantra of be kind to one another and generous with your knowledge. Thank you for your time, your attention, and that's going to be it for me for right now. I'll be watching to see what you guys want for future content, but thank you very much for your time.